Singh from Cleveland Clinic, Cleveland, Ohio.
You accept that?
You're quite familiar with the distribution of retinoblastoma globally. It's uncommon in the United States, representing about 3.5% of cases, maybe 250 odd cases per year. Whereas the majority of cases, 5,000 to 7,000 cases, occur in Asia and African nations. And similarly, the mortality distribution is also predominant in the countries from these two continents. If you look at the distribution of cases in the globe, majority of cases occur in low to middle income countries. And therefore the choices we have in the United States or field one could be very different than choices in Patna, Delhi, Hyderabad or other cities in India. And that's because why? Well, we know there is difficulty in accessing care, lack of infrastructure, misdiagnosis, long travel, income, poverty, many issues, cultural issues. So there are many challenges. And how do we overcome that? Well, through education and awareness of trying to deliver care beyond the big cities, using health extenders, making it affordable and accessible. I think the formation of the Society of Eye Cancer Society of India will be a first and important step towards national collaboration and standardization of treatment, particularly collection of data, look at the low efficacy at each centers, and then trying to lobby or seek support from governmental agencies and also some NGOs. So unless you get together as a society, the national level interventions are not really possible. And that's the real challenge. So what are the choices we have in the management of retinoblastoma? Essentially, it boils down to enucleation versus intravenous chemotherapy versus intra-arterial chemotherapy. So why we are where we are today is good to reflect upon the evolution of treatment to realize our present situation and how that may be affecting our decision making. And I'll end my presentation with using 3 recent cases under our care. So if you look at very briefly, evolution of treatment of retinoblastoma, it starts with enucleation way back in 1850 when chloroform came around. And that was lasted till 1900 for about 50 years. And for the next 100 years, from 1900 to roughly 2000, the conservative therapy that was available was predominantly external radiation. And it took many years to find out that this wasn't the best thing because the patients were getting iatrogenic cancers, the second malignant neoplasms. And then there's a wave of chemotherapy from year 2000. For the last 20 years or so, we've moved towards chemotherapy. So currently I would say the conservative therapy of retinoblastoma is chemotherapy predominant. We first started with intravenous chemotherapy, and then for the last 10, 15 years, we have had intra-arterial chemotherapy that came along with intravitreal chemotherapy. And the idea being, the target organ being the eye, you're trying to reduce the systemic toxicity and increase, and in the end, you end up increasing ocular toxicity. So the aim is to reduce systemic toxicity, but if you deliver chemotherapy to the target organ, you are increasing local toxicity. We are all familiar with this intra-arterial catheters and how it's positioned at the origin of the ophthalmic artery. All we are trying to do is deliver drug through the ophthalmic artery, perfuse the choroid, retina, and the vitreous. Right. And to achieve that, you need this huge setup of a fluoroscopic room, and all this setup, the child is there, and the arrow is pointing to the little eye somewhere there. And to deliver this, you need expertise, not just the equipment. You need highly trained individuals, interventional radiologists, and that's Dr. Masaryk, who started this program almost 10 years ago at Cleveland Clinic, and coordinator. This is our nurse coordinator, Jackie, who is busy trying to put everybody together to deliver this kind of intervention, which can be challenging even in a big center like ours. We also know that the ISE has less systemic toxicity, is safe because you do not get neutropenia, thrombocytopenia, no risk of hearing loss that might happen with carboplatin, and maybe some questionable risk of leukemia that may be attributed to etoposide. But there is a significant risk of bronchospasm that the anesthesia people are dealing with during the procedure. And the trade-off being increased local toxicity, more local toxicity. Eyelid edema, etc. are not major problems, the biggest being the ophthalmic or the retinal vascular occlusions. That can be in up to 30% of cases in different series. But we know, fortunately, that this incidence reduces as the experience in a given center increases. And some of it may also depend upon the size of the ophthalmic artery ostium. And so here it is, an angiogram showing ophthalmic artery stenosis. And what does it cause? Well, total loss of vision. So the whole purpose of using ISE, in fact, is to preserve the globe, maintain some vision, and here you have preserved the globe, but there's no vision. So it's self-defeating to some extent, and this is the limitation, one of the limitations of ISE. The other limitation I would want to point out is the quality of the data that we have. It's based on retrospective studies, selected cases, a lot of confounding variables that include prior therapy, concomitant therapy, subsequent therapy, particularly the usage of intravitreal chemotherapy that came about at the same time that the ISE became widely used. So if you look at the numbers of efficacy, for efficacy of ISE, we say, well, it's approximately 75% in 4 to 5 years. And if you were to review the data and look at the efficacy for intravenous chemotherapy, we say the number is approximately 40%. Now for group D eyes, that's what we're looking at for now. And we say, well, it's inferior to intraarterial, although there is no head-to-head trial to compare this. And some of it may be due to the fact that the intraarterial chemotherapy has been used in conjunction with intravitreal chemotherapy, whereas no such comparison has been done, or no such interventions or data has been collected with the use of intravenous and intravitreal chemotherapy. So the data is skewed by the evolving practice patterns, and that's why I wanted to mention how the treatment has evolved, has skewed our perception of efficacies of treatment. And if you were to review all the data, and I'm grateful to Vishal Raval, who did the detailed review, and if you were to estimate the recurrences of IVC that could have been prevented with intravitreal chemotherapy, we anticipate the number of overall efficacy to increase to about 70%. And this is being currently investigated by a study undertaken by Children Oncology Group in the United States. So if you were to compare intravenous with intraarterial, well, intravenous is widely available and does not need that kind of expertise and may have some advantages in reducing the risk of metastasis, may also reduce the risk of trilateral retinoblastoma. And whereas the biggest issue facing ISE is the cost, which may be a huge burden, particularly in the developing nations where the retinoblastoma is most common. I want to highlight 3 recent cases indicating our preferences in choosing different methods of treatment. If a child has a group DEI and no vision potential, particularly with neovascular changes, some suspicion for extraocular extension on imaging, we would say that it's better to enucleate the eye. But if there is some vision potential, child has bilateral disease, less than 3 months of age, we say, well, maybe we should use intravenous chemotherapy. We're trying to avoid tandem intraarterial chemotherapy. We're trying to, in a 3-month-old baby, it may be difficult to catheterize the ophthalmic artery. So here's the superior nasal tumor in the right eye, diffuse seeding, but the disc and macula are not involved. So this is a good case for ocular salvage. And the other eye has group C, a group B disease. So this child in a center was treated with intravenous chemotherapy. And here's a child who has good vision potential, similar to the first case, but the difference being that there is expected to be good vision in this eye, and the neovascular complications and the extraocular extension are not present. So here's the child who was noted to have leukocoria on a routine examination at 1.5 years of age or something. And you can see blunting of the foveal or the red reflex in the right eye. And this was due to diffuse vitreous seeding. Disc and macula were directly not involved because the tumor was nasal. So we thought, and this was unilateral, so it was a good candidate, we thought, for intraarterial chemotherapy. And this is what was done. And one can say after 3 cycles of intraarterial chemotherapy, the tumor is regressed very nicely, nasal portrait. The disc is normal, and the seeds are also trying to get calcified, and one can see here that the seeds are completely disappeared, with some becoming calcified and showing normal disc and macular vision being 20/40. So this is an ideal case, is an ideal situation, but not all are the same. So in conclusion, I would say that the treatment that you recommend depends upon what expertise you have available, and keeping in mind the long-term burden of time, travel, costs that the families have to undergo to access good care. So in general, conservative therapy of retinoblastoma with IVC or ISE would require anything up to 30 to 35 EUAs, pretty much every month for the first 3 years of child's life. That's a huge burden, no matter how well off you might be. So the choices in the end depends upon the choices we have. The choices in the United States may be different than choices that we have or we can make in India, for example. So with that I conclude, and I said, well, if you look at the global aspects of management of retinoblastoma, we say, well, there is innovation in the public health approach. We said this is a public health issue, and we look at the high-tech innovations such as intra-arterial, intravitreal chemotherapy. But in balance, if you were to improve the survival of retinoblastoma across the globe, I really think, public health approach should take an upper hand, although high-tech innovation, which is affordable, goes hand in hand. Thank you so much for allowing me to share my thoughts. I feel so privileged, and I congratulate you all on establishing this important society, the Eye Cancer Society of India.